It's my pleasure to be here tonight. As always, TBS Clinic is my favorite of all of our events that we have because we get to hear from speakers all around the world. And tonight's speaker is no exception. I'm really looking forward to this because of his tremendous digital background, which is I'm a huge fan of, and the fact that he's from Bismarck, North Dakota. Was also a big plus because I know typically when people outside of New York are able to grow their practices very well with technology when they do incorporate it. So tonight should be very exciting. Just a little bit about Dr. Anderson. He's truly in the innovative mind behind Missouri River Dental. He's a practice renowned for pushing the boundaries of technology and enhancing patient care. He specializes in advanced dental workflows, including CBCT imaging, 3D printing, CEREC milling in his daily practice, which I'm sure he's going to focus on tonight, judging by the intro slide that I see. After earning his DDS from University of Minnesota, which is a terrific school and for dentistry, he further honed his skills in his residency at the prestigious Hennepin County Medical Center and a level 1 trauma center. So guess what, guys? That means good surgical training. Dr. Anderson is recognized nationally as a KOL, key opinion leader for Convergent Dental and for Sprint Ray, something I'm also a part of. Dr. Anderson's insights on dental lasers, 3D printing have been published in leading dental publications like Dental Economics, Dental Town, and Inside Dentistry. Beyond his technical expertise, Dr. Anderson passionately mentors emerging dental professionals through organizations like CEREC Doctors and the University of Mary, encouraging them to embrace innovation and elevate their clinical practices. So truly a man after my own dental heart, I have to tell you. I see a lot of my own favorites in a lot of what you've already have on your bio alone. So please give us a warm welcome for everyone for Dr. Timothy Anderson. And please remember to stick around for your CE credits at the end. We'll have a special offer for you at the end, of course, as we always do with TBS Clinic. Additionally, feel free to use the chat feature at the bottom for converging with us if you have any technical issues. If you have some issues that are going on with CE credits or anything like that, please feel free to use that to contact us directly on panel. And for Q&A, we love questions. We love to have a Q&A at the end here. So please feel free to write as many questions you want in the Q&A. We will stop at the end and go over the Q&A. I don't want to take away any more time. We're already 7:10 in here. So without further ado, Dr. Anderson, please take us away.
Well, I appreciate the kind words, and I got to admit, I'm super excited to be here tonight because so many times I have the opportunity to speak to dentists, whether it's at the courses we're doing or whatever it might be. But so much of what I do is on a very specific niche area of dentistry, whether it's smile design or just 3D printing or CAD CAM dentistry or the lab side of dentistry. And so I was really excited for tonight to be able to talk about kind of the entire workflow. And one of the things that drives me crazy is when I go to courses or I listen to speakers or I go do a webinar and I don't get a lot of actionable insight of like how to do things and why to do things. It's just like it oftentimes it's just somebody's highlight reel. And so for me, everything revolves around the workflow. And the workflow is kind of the magic with clinical dentistry, to be honest. And it's one of the things that we're going to really focus on tonight, because one of the topics that I think there's a little bit of mystery or segmentation is the entire workflow from the patient that walks into your office with a broken tooth. It's non-restorable. It's a broken tooth. How do we give them a tooth replacement? And what I mean by that is, how do we take them from entering into our office all the way to a tooth replacement? Not how to do, a consult, not how to do a mock-up, not how to do an extraction or a graft or an implant or a design, but how do you do the whole process? And why this is important to me is because too many times we as clinicians forget that we're in the business of dentistry. We're in the business of having consumers. And we all talk about our patients, but ultimately our patients are consumers. They are buyers in our practice. They can go to another practice. So the question becomes, why are they going to you? Why would a clinician or why would a patient or a guest within your system come to you versus the guy next door? What do you offer that is different? And I love the hospitality in the hotel industry and the food industry because it's a great parallel for dentistry of like, we've got systems, we create a product, we have customers, and ultimately the consumers have a choice. And sometimes in dentistry, we forget what we're asking patients. So think about this. Like you break a tooth or a patient breaks a tooth, whoever does. Think of the steps within your own practice in order for that patient from a non-restorable fractured tooth to get to a final restoration. I mean, in reality, most of our colleagues, it becomes a consult for, okay, limited exam. Let's figure out what's going on. Oh, hey, you broke your tooth. Well, maybe I don't feel comfortable with surgery, so I'm going to send you off. So I'm going to send you to the oral surgeon, and they're going to do a consult to determine, yes, this tooth is broken, needs to come out. And maybe that oral surgeon decides it's going to be a tooth replacement of an implant. So then the patient comes back to that oral surgeon for a third appointment, and they are going to get the tooth extracted and hopefully grafted. And then they're going to heal for a while. They're going to come back to that oral surgeon for a fourth appointment for another consult to determine how did that graft work and are you candidate for implant therapy. And then there'll be a fifth appointment for the implant therapy. And then there's going to be a sixth appointment for a torque in order to make sure that the implant is stable. And then we're going to send you back to the general dentist, of which if you're a general dentist who's not technology driven, you're then going to take an analog impression. So that's appointment number 7. You're then going to send that to a lab where it's going to be outsourced. That's a third situation for that patient. It's then going to be sent back to you for try and delivery. If you do maybe an occlusal orthotic or some type of splint, or if it's an anterior tooth, you want to protect it, you're going to send another impression back to the lab. Okay. And then the patient's going to come back again for the delivery of that, occlusal guard or whatever it might be. We're talking like dang near 8 to 10 appointments for a tooth over the span of honestly kind of a year in that situation. So what we forget for a patient, imagine that's your mouth and that's your first molar or your premolar, your anterior, and how many visits that's taking. What we forget to realize is what we're asking the patient of how much time that they're willing to spend in your office. Because gone are the days of taking an hour or two away from work. When we have a patient come to our office, what we're asking them to do is to take 1/2 day of PTO. And when they do that, they are telling us that that is more important than taking that time of PTO for their family, for their vacation, for the kids' trips, for the sporting events, all these things. So the ask is huge. So the reason I paint this picture is because we've got this huge environment for a consumer that has all these roadblocks for patients to say no, which is why they do. It's too expensive. It's too much time. It's painful, all these things. And when you have the right technology and you have the correct workflows and systems in place, you can take that 10 appointment workflow of the traditional model and convert it as simple as 3 or 4 appointments. And what it does is it changes the perspective of the consumer. And that is what drives business to your practice. And so ultimately, that's what's important to me is I value my patient's time just as much as I value my time. Because if I value my patient's time, that in turn works out in my favor with less chair time in my chair. I always joke with my team, I'm the guy that wants to not see patients. I hate seeing patients. So I will do everything and maximize everything I can to not see that patient. So let's look at this workflow from the standpoint of a tooth replacement, because ultimately it starts with case selection. And, a lot of you listening here tonight are at different levels within your practice. Some of you are new grads. You've never done an implant. You've never restored an implant outside of dental school. Some of you have been practicing for a few years. You are restoring implants, but you're outsourcing the surgery and you're outsourcing the lab work. Some of you may be doing more of the surgery yourself, but you're outsourcing all the lab work. And some of you may be insourcing everything and have a totally vertical integrated ecosystem. It doesn't matter where you are on your journey, the journey is still the same. So case selection is the core foundation of any workflow. And what we're going to talk about tonight is starting with the basics of your green light cases, your abundant bone, your healthy patients, your posterior teeth. Like, That's what we want to start with. Don't start with the immediate implant extraction anterior number 9. Like don't start there. Start with your simple cases. The next stage of this is within the workflow, we've diagnosed the case, we've got a broken tooth. The next phase is we have to remove the tooth. So tooth removal is a major component of the next step. But tooth removal is only a component because ultimately socket preservation is the most critical aspect for setting ourselves up for success or setting our surgeons up for success. Because after socket preservation becomes tooth replacement, or should I say root replacement with the implant therapy. And in my world, a dental implant is the gold standard for tooth replacement. We only do fixed partials or fixed bridges if a tooth replacement with dental implant is not appropriate or not possible for that situation. And lastly, we need that digital restoration. That is what brings it all together. And for those of you who've been doing dentistry long enough, you understand that how the patient judges the whole workflow is how they felt, how they were treated, and does it look like a tooth? So ultimately, none of the previous steps matter unless you can deliver that digital restoration that looks, feels, and functions like a tooth. But one of the things that kills me is that we as dentists look at this as our workflow. And ultimately, this is a team workflow. This is not a me as a dentist. This only works if it's a team driven workflow. And we're going to talk a lot about that tonight. I'm going to hammer that a lot tonight. Now, within each of these steps, whether it's case selection, tooth removal, socket preservation, implant, or the restoration, doesn't matter. There are 3 main components that I want us to focus on. And those are really the diagnosis, the plan, and the execution. And more importantly, how we utilize technology within each of those aspects, because the key with this is the technology. Technology for me ultimately reduces the barriers for the patients to say no to the treatment that they need. It reduces the barriers for the patient to say no to the treatment that they need. Other people say that, it gives them say yes to the best or all these different things. But ultimately, we have to have the capability to remove all the reasons why, whether it's financing, whether it's time, whether it's money, whether it's appointments, whether it's surgery, pain, sedation, whatever it might be. We need to be able as clinicians to offer our consumers the opportunity and the capability to say yes to the treatment that they need. So for me, the diagnosis is the core foundation of everything I do. And there's a triad within this foundation of diagnosis. And ultimately, the focus of this is to give me, is this a red light, green light, or yellow light case? Meaning green light, easy, abundant bone, healthy patient. They're nice. They don't suck the life out of you. The yellow patients are the ones that are like, hey, good patient. Maybe there's not as much bone, or maybe there is bone, but maybe there's some medical issues that you're concerned with. And the red lights are the pain in the ass patient that you just see them on the schedule and you're like, oh God, no. Or that case where there's very little ridge atrophy, super gummy smile, super high aesthetic demands. Like those are the red light cases. We're going to focus on green light. Please, you guys, set yourselves up for success. Too many of us have early failures in our career and we don't get over the failures and we give up because we are people pleasers. And when things don't go our way, we just give up. And so start easy, set yourself up for success. And part of that is starting with case diagnosis. So the triad in my practice starts with photography. Nothing, I repeat, nothing is more important in dentistry than photography. Everything I do is based on photography, whether it's patient communication, treatment planning, follow-up, evaluation, like the whole workflow based on photography. But photography is just a 2-dimensional perspective. I need that 3-dimensional perspective. So digital radiology cone beam is critical. And I understand that technologies like these are expensive. And some of you may be looking at cone beam going, you know what? I don't do implants right now. And oh my God, I hate endo. I don't love endo at all. My associate, Tom, I don't know if he loves endo. He's really freaking good at endo, but I don't love endo. And some of you who don't love endo and don't do implants may see your own perspective and be like, I don't need cone beam. We're talking like 60, 80, 100, $120,000 for a piece of equipment. And what I challenge you is the value of cone beam is not tied to endo. The value of cone beam is not tied to oral surgery and doing doing extractions and third molars and implants. The value on cone beam is diagnosis. The value of cone beam is diagnosis and giving you the ability to treatment plan and green light cases that you want to start with. And having the ability when a patient comes to you in pain and having the capability to accurately and definitively tell them what is going on is the best marketing strategy I can think of, period. Having the ability to tell the patient, hey, this is why you're in pain. I have a solution for you. You don't need to do the solution, but you need to be able to diagnose this. Nothing's worse than having a patient come in for a limb exam, taking PA and go, I don't know, let's send you to the endodontist and maybe they'll figure it out. Like, tell the patients what they need, but you need the right data and right information. And honestly, I promise you, I've never met there's certain things, certain technologies. I've never met people that have invested in cone beam and we're like, you know what? That was a big mistake. I shouldn't have done that. Usually it's, I should have done this years ago. I didn't realize what I was missing. The final component to the diagnosis trio is intraoral scanning. And can you do a lot of things with alginate, VPS, polyether, rubber base? Yes, you can. But what I will say to you is that without intraoral scanning, you cannot unlock the capabilities of digital dentistry. You need intraoral scanning. And unlike cone beam, intraoral scanning has gotten ungodly inexpensive to the point where, with some of, Shining 3Ds and the Medits and some of these units, like in reality, we can have one in every operatory. Like it's gotten to the point, it's no longer a $60,000 piece of equipment that's just for the dentist. It's now used for hygiene. It's used for all the restorative assistants, doctors, everybody. So this trio is what makes everything. But like I said, my priority and my number one, photography. I love photography. For anybody who knows me, I love photography. And there are two different types of photography. You have your large scale, full mouth photography. Those are your SLRs, this is the Shofu point shoot, stupid expensive, but it's really nice and my hygienists love it. So we use it. We have one in every op because of them. And then you have your intraoral scanners. And too many times I see dentists use these wands as their primary source. And the problem with this is these little wands do great for cracked teeth, but all they do is one tooth. And if all you're taking pictures of is one tooth, guess what you're going to do? One tooth. You're not doing comprehensive dentistry because you don't have the capability or the ability to treatment plan. So I think there's value in both, but I would rather have full mouth dentistry than anything. Intraoral scanning in my office, I can't even tell you the last time I intraoral scanned, to be honest. Like my team, this is a team-driven workflow. I promise you, your team will become better at this than you, doctors. So you got to give it up, whether it's crowns, occlusal guards, dentures, surgical guides, it doesn't matter what it is. But the intraoral scanning these days is so insanely accurate, so quick that it honestly has become the cornerstone of my entire workflow. So photography is a component, but like I said, we're doing a workflow here. So this is my patient, and we're going to work through his entire case. And this is how he presents to me. And Bo is a super nice guy, but he had a large restoration and then he fractured everything. I mean, it is way below the bone. We got caries. This thing is toast. Okay. So 2D radiology is very important, but it only gives us a starting point. So when I look at 2D radiology, what I'm looking for is like, where are the bone levels? Like, where's the alveolar crest? Is it like, do we have relatively good foundation? And then the PAs I'm looking at, is there major periapical pathology? Like, is the sinus like crazy pneumatized? Like, what are we looking for? But it's only a component because I need that third view. And that's where cone beam comes into play. And when you bring in cone beam, I'm telling you guys, you can't unsee this stuff. It is so critical on how we treatment plan, how we look at things, because when you look at Bo's case here, you can recognize like, holy crap, that's a very involved tooth. And now you understand why it's non-restorable. I mean, you compare the 2D versus this and you can see things. But what I want to challenge you is this also is that first diagnosis step for me trying to determine, okay, here's the tooth. And what we can see based on this is like, man, these root forms are way towards the cortical plates, like to the point where the cortical plate is just like a paper chip. And so I know that this is probably not the best immediate implant case, just based on this one slice. The other thing I'm looking for is where are the cortical plates? And then also, where is the sinus cavity? And so when I look at this, I look at, hey, what's great about this is the root is not near the sinus, but I don't have a lot of cortical plates. So I know I want to build and preserve this bone to set us up for success later. So all three of these become part of the patient kind of digital chart or the digital patient. When I mix my photography, my intraoral scans, and my cone beam, all of a sudden I have this working platform to then start really treatment planning. So for Bo, I know that, hey man, I'm sorry this tooth happened to you. I'm sorry, it sucks, but you got to lose the tooth. But don't worry, we can do a tooth replacement. And because we've invested in the right technology and the right workflows, we can do everything here for you. When do you want to start? And then we start moving forward. And the first step with Bo's case is tooth removal. And tooth removal, when we look at this, this is something that I learned the hard way based on my education of where I went to school and then where my residency was and then where my continuing education went. Because when we start looking at tooth removal, there's three components I want us to really focus on. One is access. And I will argue that new clinicians, you don't have enough access. Like we're trying to do these mini baby flaps and we're afraid to reflect the tissue. And what we end up doing is just breaking shit. And then we've set ourselves up for terrible success. And there's a balance because I don't want to flap, crazy. But what I want to challenge you is an incision that is 3 millimeters long versus an incision that is 20 millimeters long, which heals faster when primary closure is achieved. And the answer is it's the same. So I'm a big advocate for larger reflections so that way we have good visualization, good access. So that way we can do a very atraumatic, which is a total pun and buzzword, but we can do things very atraumatically without breaking stuff and having to cause trauma. It also increases the speed of the surgery, which has been shown to reduce trauma, inflammation, and all of that. So fast surgery is a good thing. The other thing is when we look at expansion, because when we want to remove teeth, you either have to make the tooth smaller or the space bigger. Okay. Think of a bowling pin. Like you have to make one of those decisions. And that's a challenging thing when you're early in your career because that's not necessarily how we're taught. And so the key with this is how do we expand the bone to remove the root or the remaining tooth structure without damaging the rest of the alveolar bone? Because that alveolar bone is critical to long-term success, whether it's this, a paper chip or whatever it might be. Having a defect that has 4 walls versus a defect that has 2 walls is dramatically different. And the last component of this is preservation. And ultimately, this comes down to how we can preserve natural tooth structure, not breaking the buccal plate. How can we keep that foundation to help us out? Now, I understand oral surgery. Like when I've taught enough dentists that like when you start talking oral surgery, it's like this mindset of like, what's the instrument I need? And there are hundreds and thousands of instruments that do almost the same thing. And you look at individuals' cassettes and instrument bags, and they are just littered with a stupid number of instruments. And it kills me because ultimately, we don't need all of that. We need strategic strategies and instruments that do a purpose to address that preservation, that expansion, and that access without damaging the structure so we can build our implant platform. And when I was taught in dental school, you guys, and I don't know about you or where you went to school, but I was literally taught kind of the whole grip and rip. Software. There we go. Grip and rip. Like literally, I was taught to take an elevator, a large elevator, start like wiggling back and forth, try to get it wiggling. It wasn't wiggling, grab a forceps and start wiggling that way. Like it was mind blowing how I was taught to do surgery in school. And then in residency, it changed. And what residency taught me was the purpose of intent and having intent when you do things. And part of that was using instruments like an elvatome. That was a new instrument I'd never heard of, or an apical luxator. And the reason these instruments are different for me, and why honestly in my world I literally use two instruments almost. Like I use a blade and then these two instruments, because the focus is to use apical pressure to go between the ligaments, or go in the ligament space between the alveolar bone and the tooth to expand that socket. And it's done in like a apical rotational movement. And it's not just like putting, like, what I love is when you see somebody put an elevator into a tooth and they spin it the wrong way, and you're literally elevating the wrong tooth. And what people also don't understand is like bone compaction takes time. You have to put apical pressure, push and hold, push and hold. You have to give time for the bone to compress and expand. And when you do this, great things happen. But you'll notice on this works perfect for incisors, single rooted teeth. But when it's multi-rooted teeth, the one thing I teach every clinician I talk with, or my associates or whoever, is section early and section often. And to be honest, if it's multi-rooted, always section. Like we all want these amazing Instagram photos, like on the left here of this like amazing multi-rooted tooth. Like that's a wisdom tooth that happens once in a blue moon. In reality, if your goal is tooth replacement, the bone is exponentially more important than the tooth. And the furcation bone is not as important as the buccal and lingual cortical bone, because as long as we've got our four walls, we've got a great socket to graft. So what I mean by this is when you have a broken tooth like this, take your surgical, do not try to start elevating and go to town. Take your surgical burr and cut the crap out of that crown, view the pulp chamber, view everything, and then section your tooth. And then when you section your tooth, then you take those elvatomes and those apical luxators and you press down and you rotate and you do it slowly with pressure. And all of a sudden you take one single rooted tooth out at a time. And what you're left with is this amazing socket that is so insanely easy to graft and preserve and set yourself up for success. Versus if you just grab this multi-rooted tooth with the 23 forceps or the cow horn, like we called it in school, and you start grabbing, you're probably going to break the buccal plate and you're going to totally crush all the furcal bone and you're going to totally set yourself up for failure. So do yourself a favor and section early. You want to preserve that, because the next step within our circle after we get the tooth out is socket preservation. And this was a term, like bone grafting was like, oh my gosh, it was like this topic we didn't want to talk about because that was for periodontists or oral surgeons, or you had to take a boatload of CE. I'm like, if you're willing to take out the tooth, that is exponentially more difficult than plugging the hole. I kid you not. It's not rocket science, especially in these green light cases. The key is access. You need visualization. You need access to be able to see it. You also need access for when you start tucking the membrane and doing these things. So you need availability to see things. The other aspect is you need vascularity. This is one thing I see clinicians miss. We are not curetting the socket. We're not getting all the tissue out. We're not stimulating bleeding. Blood supply is gold. It's everything when it comes to grafting. The other aspect is filling. Filling what type of graft? It's super confusing. I'm going to give you a recipe to start you off that's super simple. And then protection. How do we cover that graft up so that the graft actually takes and we don't have just soft tissue infiltration and it just washes out? So let's talk about the fill. When it comes to graft material, there are not that many options in reality. We've got our autografts. Those are the self-grafts that would be harvesting from tissue, the dent and grinders, all that kind of crap. I don't really use autografts that much in my practice. I'm not doing block grafting. You've got your allografts. Allografts means it's human bone, but it's from another donor. It's usually acellular, it's just a matrix, so it's not, you don't have to worry about contracting diseases or anything like that. You have your xenografts, which are your non-human, so your animal grafts, that your bovine and all of those. So those are there's uses there. And then you have your synthetic, your alloplastic grafts, and those are, honestly, I don't use those. The only time I've ever used a synthetic graft would be like in a bridge site, because those don't resorb and you can't really put an implant through them usually. So I'm like, it's just not for me. What I want us to focus on when we're looking at these green light, getting into socket preservation, are allografts. Okay. The allografts, and allografts get confusing because you've got cortical allograft, cancellous allograft. Sometimes it's mineralized, sometimes it's demineralized. And what all of these properties, and I'm not going to go into this tonight because that would be its own lecture in itself, but a lot of these properties involve the osteoinduction, the osteoconduction, how well it preserves the bone site, all of that. What I will tell you is, if you're doing a posterior traditional socket graft, premolar, molar, even an anterior, when you're not doing an immediate implant, really what you want to have is really a mix. So I like a mineralized cortical cancellous mix, because that gives me the best benefits of building bone, but also preserving the size and the volume of bone. And that works really well. There are other indications for, I use cancellous bone or a different mixture of cancellous to cortical when I like 50-50 for this purpose, but sometimes I like 80-20, or there's other reasons if you're doing immediate grafting around an implant, like filling the gap. But for this purpose, we just want a good foundation to build bone. And the bone filling is really simple. It's not rocket. You're literally just packing bone chips in a hole. Like you're filling a hole. It's like, for those of you who have done amalgam, I don't even know if they teach amalgam anymore, but it's like filling amalgam preps. Like you're just packing, tap, 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 packing, tap, 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 and then covering. And what we cover or protect the things is with a membrane. And really, there are only two categories of membranes in reality. You've got your resorbable, non-resorbable. And the resorbable membranes, there's a whole list that you can do: collagen membranes, collagen plugs, pericardium, acellular dermal matrix, PRF, like all sorts. The non-resorbable, you got your PTFEs and your titaniums. PTFE, you've got the old school, the ePTFE, and now the new dense PTFE, which is what most of us use. There's less reason, and it can be really confusing when to use what. And ultimately, you can use a lot of these in different situations. Like you can use a collagen plug a lot of times in the right situation. You could use a membrane, or you could use a pericardium, which sticks around a lot longer. But ultimately, it's resorbable versus non-resorbable. And what I want you to make your decision tree based on of, if you can get primary closure, you can use the collagen membranes. Or let me backtrack. We want to look at just collagen membranes and PTFE, like what I want us to start with. But when we look at resorbable versus non-resorbable, it's really primary closure versus open socket. So if you can get primary closure, feel free to use pretty much any membrane you want. But the collagen membranes are great because then you don't have to go back into the site and remove it. If you have an open socket, so like in Bo's case where I've got this big molar that I'm removing, I'm not going to get primary closure. If I do that, I'm going to have to reflect like a huge flap. And so in that situation, I can't use a collagen membrane, or ideally wouldn't use a collagen membrane. I'd probably prefer something like a non-resorbable PTFE membrane. So let's take, I'm a visual person, so let's look at this really quickly, because this was the part that nobody talked about. Okay, so I have this tooth. So here's Bo's tooth. We got his tooth, right? So the first thing I do, I need access. Remember, that was the critical point. So I'm going to make a reflection. The palatal reflection is a little bit less than the buccal. The buccal is going to be more. And then I'm going to use those instruments with apical pressure to expand the bone so that I can atraumatically remove that tooth and preserve all that bony architecture. And then from there, what I'm going to do is I need to clean out that site. And so we have to curette the crap out of this, you guys. All that soft tissue is going to regranulate and get granulation tissue. So clean it out, and then you're going to get blood supply that's going to usually happen after that. So if you have a site that you're scraping is bleeding really well, awesome. If you're not, you want to stimulate bleeding. Bleeding is your friend in these cases. Now, this is why I prefer instruments that have serrations. So the serrations are important because that is what's going to stimulate this. So you're scraping, 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 and what stimulates the bleeding is the striations or the scrapes. So I like a spoon curette that actually has some grit to it. That's my personal preference. Now, after that's done, I need to place my membrane. So I usually go from the area that's least reflected. So in this case, it'd be the palate. And because this is a socket, I'm going to use a PTF membrane. Now, the thing with PTF non-resorbable membranes is they're not going to resorb. So I got to go back in and remove that. And we'll talk about how long you leave that in. If it's a resorbable membrane, I know I need primary closure, and that will dissolve on its own. So what we do is we place the membrane and we tuck it in there. And then the next step, you guys, this is the magic of bone grafting, is you fill the hole. Like, you don't have to condense it like crazy. You just place bone graft. And there's two different ways you can do it. In this diagram, I'm using this really cool like syringe of graft. And what's awesome about that is you like literally squirt it in and you're done. It's awesome. You can also use a vial where you're going to mix saline and then you're going to hydrate it and you got to spin it up and then you got to put it in there. And what I find with those is it's okay, but you need 4 hands to do it because it makes a mess. You got the bleeding and suction. To be honest, I just like to stick the syringe in and fill it up. It's way, way easier. Okay. Especially when you're starting out. As you get more used to grafting, then the powder mixtures are good too. But ultimately, we're going to use a mineralized mixed cortical cancellous bone to fill this socket because it's got a good posterior. We're not worried about it. So now that we got filled it up, and I like to excess fill this just a little bit. So you'll notice in the diagram, it's just a little bit overfilled because we're going to have some resorption. And then I'm going to tuck my membrane. And this is critical. When we tuck that PTFE membrane or any membrane, we want to be very intentional of making sure that it goes below our release. Like it needs to tuck in. Like it needs to be ideally kind of like watertight, but it just needs to tuck in really, really well, because then we're going to lay down the tissue on top of it and it should create this sandwich. And then we need to suture it. And if I'm using PTFE, that's non-resorbable. So in that situation, I'm okay with a non-resorbable suture. But if I was using a membrane or something like that, I want something that's resorbable. And so if I'm using a resorbable suture, I'm probably going to prefer something like polyglycolic acid, like PGA sutures, not chromic gut. The reason for that is it's going to be you're going to get a better tissue response, but honestly, it's because it lasts longer. It's going to last 4 to 6 weeks or even longer. And I want it to last that long because I want my PTFE membrane in there for at least 4 to 6 weeks. I could also use PTFE sutures. If you have never used PTFE sutures, they are, oh my God, they're better than silk. They're awesome. They just tie so easily. They're nice. The problem with PTFE sutures is the tissue loves them. So you want to make sure you have long enough tails that you can see them, because sometimes the tissue grows over the whole thing. And so you got to be able to find it. So let's look at Bo's case, because we removed Bo's tooth. And now this is where we've kind of put his membrane on the palate and we packed it with bone. So I'm overfilling it. Now, what you'll notice is this membrane, this PTFE membrane or cytoplast, looks as though it's perforated. It's not. It's actually a very dense membrane so that bacteria can't infiltrate it. That's the big difference between the ePTFEs and the dPTFEs. So when you're looking at the PTFE membranes, you want a dense PTFE membrane. They just will work better. And what you do is you then tuck this over into the buccal, because the buccal is very, flappy, and you tuck it under, and then you're going to place your sutures. In this case, I did PGA, and then I'm just doing 2 interrupteds, and then I did a couple crisscross sutures to tie it down. You just want to hold it all together and reapproximate the tissue. And the key here then is you have to let this sit for 4 to 6 weeks. You have to let biology win, you guys. Just leave it alone. And when it comes back, it does not look like this. So when you see them back in 4 weeks, this is what it looks like fully healed. When it comes back in 4 to 6 weeks, this is what it looks like. You've got this weird yellow plaque because that's all the plaque and crap that's stuck to the outside of the PTF membrane. And then when you can see a little bit of the PGA suture that's still remaining, what you end up doing, and my team member, this is a team driven thing. So when suture, like when this appointment comes in, I don't see the patient. Now, mind you, this is a workflow thing. This is a non-doctor appointment. This is a assistant chair appointment. The assistant comes in, snips the suture, and pulls the PTFE membrane. When they pull it, it's going to look like the picture on the right. Will there be potentially some bleeding? Yes. The one question I always get is, Tim, do you numb the patients up? I will honestly tell you 2% of the time I have to numb them up. And it's usually because I did a PTF membrane that is way too far extended and it's kind of stuck. Or I made a crinkle in it and the tissue's kind of grown and like engaged it. So usually these are non-anesthetic appointments. They're just driven by the assistant. It's really quick, in and out. My assistants, I train them to take photos on every one of these. So that way we have a record of what it looked like, because I don't learn unless I see what it looks like. If I'm seeing all my membranes look like crap, I got to figure out what's going on. So take photos. This is what it's going to look like when it comes back at 4 to 6 months. So now we've got this nice healed site. And like I said, it takes 4 to 6 months. Let biology win. But when you do this technique, this is where you start and this is where you end. It is so insanely predictable. It's stupid. And I love, resorbable membranes, but man, I love PTFE membranes for socket preservation. They just work amazing. So you look here, like, look how much bone we have. Like now this is like, God, this is a slam dunk. There's like 18 millimeters of bone here. And so I plan my implant, and this is a 12 millimeter implant. Look how much bone this is the biggest green light case ever. I don't even need a guide for this. Like, you can't screw this up, like, really. But because we're a digital workflow, we're going to work this. And now is when we start the fun stuff, because it's the tooth's out, healed site, healthy patient, healed site. That is the foundation for all the fun digital side of dentistry. And why do I think it's fun? Because then I get to play with my toys. So my two favorite toys that I start with outside my camera are my cone beam and my intraoral scanner. And what we do is we take those healed sites and we combine the data. That is how we create our surgical guides. And I'm a huge advocate, learn free-handed surgery, but every case you do should be planned, guided. Whether you use the guide or not, I don't care, but you need to plan the guide, because when you plan the guide, you learn and you're like preoperatively doing the surgery. It makes the surgery faster, more efficient, more predictable. But when you start doing guided surgery, most individuals are going to utilize their lab technicians to create their guides. And I'm okay with that. The problem with that is you then have to communicate on the lab schedule. And I don't know about you guys, but like, my schedule is a total cluster. Like, even trying to find time to do this webinar was hard. Like it's just, our lives are crazy with our kids, our families, our activities, and our practices. What's helped is the use of AI technology and these other workflows. SprintRay's got one, a bunch of other companies have one, to start doing design services that either use AI or a combination of AI and a person. But eventually, you're going to want to start doing in-office design. And that's where the magic is, but you need to wait till you're ready, because this is a team-driven thing. Now, when I started getting into digital design, it was complicated. Like, I started with CEREC, like start with single unit crown, and right away that was complicated. But what you start finding is every CAD design software, it's all the same. It's just how the buttons roll and what does right click and does left click. And so as I got further along in my journey, I started realizing the value of having an integrated software that allowed me to design everything using the same scroll, right click, left click, and all that. And that is why I started investing in things like exocad. So in my practice, we use CEREC chairside, we use InLab, we use a little bit of 3Shape, and we use like a ton of exocad. Exocad is like our go-to everything. Okay. And the reason for that is how simple it is. So this is how I create a surgical guide. And the first step is just merging the data, merging that cone beam with the intraoral scan. So that way we overlay them together. And it's literally a matter of clicking 3 clicks and then it stitches. It's stupid accurate. Like, absolutely stupid accurate and fast. And then we always do restoratively driven design, meaning we are planning the restoration and fitting the implant, if we can, into that restoration so that we have an idealized outcome. And so that's what I really like, is that I can create the restoration and tweak it. And by we, like my team can do this, I can do this, anybody you can do this. If you know how to use CEREC, you know how to use this. It's all the same. You're just designing a crown. And then what I'm doing is picking my implant system, placing it into that digital design, and then idealizing it in that cone beam data so I know I'm in my safety zone. So like this case with Bo, like I've got bone everywhere. So this is a super safe situation to get a very good screw retain crown because the access is coming right through. So I'm planning it. I know this is going to be simple because all those risk factors, because of the photography, the cone beam, the intraoral scanning, the graft, the atraumatic extraction, the grafting, all of those things set us up for success. So I plan the implant, that's phase one. And now I just need to make a guide. And guide fabrication is making an occlusal splint. So if you make splints in your office or you have AI design a splint, it's literally a splint with a hole in it. The software determines the height of the hole, but literally you're making a splint. That's all you're doing. It's actually easier than a splint because you don't have to deal with occlusion. You're just making, the splint bubbled. And then I make a couple windows so that I can verify that it's fully seated. It's literally a matter of just moving them, adding a couple. Like I wish, when I talk to people how easy this is, it's so easy that I've gotten to the point where my team hates me because I will design these literally the day of or the night before. Like that's how fast I can design this. So on average, this takes me 10 minutes, maybe 15 to design a guide. I mean, you're watching this at 2 times speed right now. So it's just a matter of going through, making sure everything looks good. And there is my occlusal guard or my surgical guide, my occlusal guard with a hole in it. exocad allows me to simplify the process and take out that like feeling like I'm doing the designing or the lab work. I need the software doing the heavy lifting, not me. It also gives me the capability to communicate with my lab, which I work with my lab heavily. It's just for these simple cases I do it myself. So like I said, merging the cone beam and the intraoral scanning is priority number one, but doing that crown down strategy of designing the restoration first to do this. Now, one thing that I will tell you is while I use exocad to design my surgical guides and do this crown as a design, my actual crown workflow is actually with CEREC. And the reason I do that is because that's an assistant team driven thing. They can do all that. So I use this as my planning guide to get me to the home run, but it's not my actual final crown design. So that's why I don't have to spend an eternity making it perfect. So now that I've got my guide, now I get to get probably my favorite piece of equipment in my office, and that is my 3D printer. 3D printing is the one tool that unlocks the capabilities of your intraoral scanner and your cone beam. Without a 3D printer and additive manufacturing, you don't have the capability to utilize all that amazing digital data that is being collected by those other two devices. So I've taken all this digital data. Now I'm going to import this into my printer software, and that literally becomes drag and drop. You literally like drag it into the software. You tell it, hey, I want to do a surgical guide. I'm going to pick my surgical guide resin. With SprintRay, there's really only one. And then I let the AI do everything. So you'll notice I put it on the build platform. I hit next, and then I don't do anything. I let it spin around, do its thing, and it bases it for me. It puts on the supports. I'm going to verify that the supports are in proper spots. And then from there, I literally hit next. Here's a list of all my printers. I'm going to select the printer that's got the resin in it. And I hit next and I'm done. And by I mean, this is my team. Like this is 100% team driven. And what I love about this is it's so fast and predictable. Literally within 15, 20 minutes, I've now got a surgical guide. But we're not done yet because the surgical guide, I still need to process it. We put our little, our guide tubes, and the guide tubes, depending on the system you're doing, most systems have a guide tube. Like it was one of those things nobody talked about. And so with the guide tubes, here's a trick, you guys. So when you're removing Like what I love about surgical guide resin, like you don't even need the little spatula thing. You like rip that thing up the build plate. It is like the easiest resin to remove supports. So you remove all that, and you'll notice my assistant is trying in the guide tube and it's not fitting. I'm a mountain biker. If you like, if you bike and you've ever put mountain bar handle or like handlebar grips on, you have to like spray alcohol in order to get them to slide on. Otherwise, they won't slide in. So what she's doing is literally painting the surgical guide with alcohol or dipping it in there, and watch what happens. She puts it in and it just snaps and slides right in. Boom. It's so easy. And now she's going to then put that into my cure box. Now, if it was so tight she couldn't get it in, then I know I need to adjust my parameters on my print software or my design software, or I just grind out a little bit. Or if it's super loose, just add a little bit of resin, glue it in, or super glue it. Like guided surgery is not 100% precise accurate. It's close. So don't worry about these little tiny degrees. Now it's surgery time. Now is the fun time, because we're going to make our surgery. When you do your initial release, like look at this bone here. Like I've got this amazing buccal, like remember the pre-op, you guys, that buccal, mesial buccal, distal buccal root were like into the whole cortical plate. Like I've got this great bone block to drill through. It's amazing. Verifying our surgical guide fits. We've got our windows that we can see everything. And then we do our osteotomies. And with guided surgery, it takes longer to numb them up and flap them than it does to the surgery. Like the surgery is stupid fast. It's one of the best parts about guided surgery and using digital surgery is that the surgeries become exponentially faster the more you do them. Like to the point, like you can be done in 40 minutes, half hour, like you're just done. And I looked at my assistant today, we did one. I'm like, just think, we could be prepping number 2 subgingival into no man's land on a gagger who doesn't want to do this crown, or we can be doing this implant on a patient who's desperate to give us money to do the case so they can have a tooth again. And this took us 40 minutes and outproduce that crown. And ironically, we get to do the crown later anyway. So for me, implant dentistry unlocks this capability with your practice. Like it unlocks the emotional side of dentistry and allows your patients, like emotional dentistry is what your patients want to do. It's not what they have. Nobody loves a single unit crown. Most people love an implant because they're like, please give me a tooth. Like it's so great. But now we've placed this implant, and now we got to look at technology in a different way, because most of us, when we're trying to determine the stability of this implant, we're going to use torque, right? But there's a difference between torque and stability. And so what I mean by that is torque is just a measure of frictional rotation. So look at these two cases. Like the one on the left, we've got very minimal cortical plate, dense medullary bone, and we're going to have 30 Newton centimeters of torque. On the right side, we've got thicker cortical plate, but the inner bone is just empty. Like, and you've seen those cone beams where they're just like completely ghosted empty, yet we still get 30 Newton centimeters. The problem is these will integrate very differently because the stability of the one on the left is much, much higher than the one on the right. We can get a false sense of security of the one on the right because everything is engaged in the cortical plate. Now, if we sink this too deep, what happens is as you keep going, you'll notice your torque value gets less and less and less. And some of you have seen this where you're like, torque value 35, great. Oh, I got to go a little deeper. Now it's 25. Go a little deeper. Now it's 15. Now I got a spinner. It's just that bone density is just not there. That's very different than using technology that measures the implant stability. And really what that is a measure of the stability in the bone contact. And so that's what the implant stability, that's the ISQ. If you heard people use ISQ, there's different, there's the Austell, the Penguin, there's all sorts of different things. But what that gives you is a resonance reading of how much contact the bone has with the implant, which in my world, I use both of those because it gives me an idea of integration. So if I have an implant that torques very low or is in really lackluster dense bone or an immediate site, I'm going to use my ISQ as a better indicator of stability before I'm ready to load that. And so anything above 70 is really good, 60 cautious, 50 I got to be aware of. And really what I use it for is I'm going to use that with my torque value to determine, am I doing a cover screw and burying the implant, or am I going to do a healing abutment? So the way this looks is it literally, you just put this little peg on, screw it on, and then you use the ISQ reader to just measure it, and you hover it over it and it beeps, and then you take it off. It like crazy easy. You don't like stupid easy. But I do all of this, and now I've got my final implant, like guided into place, looks good, a little bit subcrustal, just the way I like it. And more importantly, this is 2D. Let's look how it was on 3D. And it's exactly where my plan wanted to be. And that, like, every time I do one of these cases, you guys, I'm so shocked. Like, holy crap, it worked. It actually did and went where it did. Now, the next level of this is, when do you take your impression? Because I would argue now, in this type of case, you take your impression now. This is when you take your impression. And some of you are like, how do you do that? The key with this is, those of you working with digital CEREC workflows, you have to take a pre-operative scan before you do all this. So in this case, you can see I made my incision. I was like, oh shit, I forgot to scan. And so we scanned it because I need the scan for the proximal contacts. So there's the 3 scans that we use. One does the proximal contacts, and one is just the timing of the implant within the system. So I need a good preoperative scan, but this scan, I don't care about. All I'm getting is the timing of the implant. So that, don't be afraid to do this. And if you don't trust me, start on a posterior tooth, try doing this, make crown head time, and you'll be shocked. Now, the key to this success is, most of us, when we get to this point, are going to use a stock healing abutment. Problem with a stock healing abutment is we create this super healthy tissue, but look how like narrow that is. I literally, here's the scan post. Like, how the hell am I going to get a tooth in here? This becomes a lollipop on a stick. Or in my practice, what I choose to do now is utilize my technology, my 3D printing, to create something like this. And what this is a custom 3D printed healer. And the reason I do this is now I get tissue that looks like that. Now I've set myself up for crazy easy delivery, because the last thing I want to do on a delivery is numb the patient up. So what this is it's just a custom healer. It literally is on a tie base, and it's pre-printed. And what I love about that is you can pre-print them. So the pre-prints are awesome because I have a boatload of these already made. Now, what's amazing about this is I then glue this to the tie base, and now we're ready to go. What's even better is you can use software like True Abutment, and you can actually go directly to fixture. So you don't even need a tie base. You just need a screw to hold them down. And True Abutment, when you order their abutments, come with a lab screw and a prosthetic screw. So I will keep the lab screws in a drawer, and then I'll use those for the 3D printed direct to fixture. Like, it's whatever you choose to use. There's not a right or wrong. It's just some people get hung up on the tie base. So this is what I end up doing in Bo's case, where I put it up here. Now, the reason I think this is a better way to do it is, yes, I get the cool anatomic features, but look at the buccal roll that I get on the facial. I'm building that keratinized tissue. And what's amazing about that is they come back and this is what he looks like. Like, that is so much better than that tiny little hole. Now I'm ready for a restoration. So when they come back, the cool part about this team-driven workflow is it's now based on the patient and my team. And my team is the one who does the scans. I don't even do this. Like, I just verify the scans. I don't take the scans. So my team's going to do the jaw scan, the opposing, the scan, body scan, all of that. And whether you did the impression at the beginning, or in this case was at the end, is up to you. Now, what I want you to look at here, this digital workflow is, for those of you doing CEREC or tie bases, there's a big hang up on like tie bases suck. Like, got to have a custom bubble on tie bases. And part of that is just an understanding why, like, the difference of when to use it and how to use it. And in this case, this is a great case for tie base. But if you look at this tie base right here, this is green. It's not the same as the pre-op or the one we did before. This one is a true abutment. And the reason I like the true abutment one is because this is a standard tie base. But what I hate about this is then the emergence of the bone, if it's subcrustal, is like there's no running room. What true abutment gives me the opportunity is to have a tie base like this. So their scan posts have different heights that I can pick and choose. That changes my ability, because now I can have cases where I can design it based on the gingival height and I can elevate it off the bone. So having the right technology in the digital workflow allows me to customize it based on those patient needs. It's not a one fix for all. It allows me to kind of go through and design it. So Bo's case here is like a super simple case, but you can imagine if I didn't use the custom healer, I don't have this amazing emergence. And if I didn't do a guided surgery, it's probably not in the right spot. And if I didn't do the bone graft and the atraumatic extraction, I didn't get to put the implant in the right place, and I don't get to maintain all that stiff tissue. Tissue follows bone. Tissue is always the issue. And then we go through and we design our crown. And so this is just like any other CEREC crown you would ever design in your practice. We're using in-lab here. That's why it looks great. It's the exact same thing as chairside for the most part. So when you design this, it's just like designing a singular crown. The only difference is you have to then contour the subgingival contours. So docs, teach your team how to do this. When is contour okay? What is too much pressure? When is not enough pressure? And allow them to go through the process. You can overlay the screw channel so I can see, because we did a crown down design, this is right through the center groove. Like this is perfect. Like I love this. Like I couldn't have had this better. Like if my surgeon gave it to me, it wouldn't be like this. Like I knew this was going to be like this because we designed it like that. And with 3D printing, you can take it to another level, because some people like, Tim, I need a model. Well, perfect. If you have a model, if you have software, perfect. With CEREC, I can make a model. I can even make a gingival mask on that model that's removable with an implant analog. Like it's super cool. But the best part about all of that is it is a team-driven workflow. I don't have to do it. This is team-driven. So what happens then is my team designs the restoration, and now it's time to fabricate, and they fabricate it just like they do every other restoration. In Beau's case, this is a perfect situation for a screw-retained lithium disilicate crown. Single piece, super simple. Not every case is a screw-retained crown, right? It doesn't matter. With my CEREC software, I have the capability to split the case and split it up into a custom abutment on a tie base and a crown. And when I split it onto a custom abutment, what I like is I like a zirconia polished abutment, because polished zirconia, there's nothing on the planet from a material standpoint that's better for the tissue. You get hemidesmosomal attachment to polished zirconia, nothing else. So I like that. The other thing I like with zirconia is I can infiltrate it, so I can stain it down to a dentin shade and then overlay a glass ceramic like lithium disilicate on top of it to mimic the enamel. Now I get a crazy aesthetic result that I couldn't do with a monolithic screw-retained crown. Or we start opening the doors for more 3D printing possibilities. And with these new resins that are so highly ceramically filled that mimic enamel and dentin so much better, now this has become probably one of my favorite implant restorations, which is a split case that is a custom zirconia that's polished with a 3D printed ceramic crown on top, but it's glued together and it's screw retained. So I get the benefit of all of it. I get the benefit of the color hue of the zirconia, the polished zirconia. I get the mechanical properties of the 3D printed resin. Like it is just amazing, the world we live in with digital technology, that my lab, like if I ask this to my lab, they're gonna be like, what the hell are you talking about? Like to have the control is just so amazing. The goal with this is to have a lab quality restoration. If I can't do it lab quality, I'm not going to do it. And so your digital design from your team to the execution to the true tooth replacement. And whenever I do these cases, I got to protect the tooth. And so the next level of that is creating a night guard or some sort. And that's assuming the airway is good. We usually do a lot of sleep studies. So if the airway is good, then we're going to do an occlusal guard. Now, the cool part of this, I'm using the same lab software to design these as I did before. And you could have your lab do it. What's awesome is that Sprint Rate can do it with AI in a matter of 5 minutes, or you can do it yourself. But these are such unbelievable services to a patient, and literally it takes 5 minutes to design. It's AI. If you do the AI, it's about 2.5 minutes to design. And then 3D printing these takes about 15, 20 minutes. So I can do this in a single visit, and it changes the perspective. So let's backtrack and think about this. From a workflow standpoint, we've got a broken tooth. The traditional workflow is send it to OS, then we send it for OS for an extraction graft, then we're going to do an implant, then we're going to do a torque, and then we're going to have them back in our office do an impression, but then we got to send that impression to a lab, and then they're going to do an abutment delivery in our office, and then we're going to send it back for another impression for the occlusal guard, and then we're going to deliver it. We're talking 8 to 10 appointments. If I do it with a modern digital workflow, utilizing the right technology and the right materials and the right armamentarium and instruments, I can take a broken tooth, I can plan it, remove it, preserve it with socket preservation, so remove and fill. I can then take place the implant, take the final impression that same day, have them come back, deliver the abutment, scan it, deliver their final guard in a single visit. 4 appointments to go from tooth to actually having a tooth and a protection night guard. It changes how we look at things. So getting back to that, case selections, everything, photography, cone beam, digital scans. Tooth removal is that next step. Section the tooth, the right instruments, the elevator and luxotome. I'm telling you guys, apical pressure, quit using the grip and rip technology. Socket preservation, the mixed cancellous cortical bone is the backbone of your grafting. That's where you should be starting. And then PTFE membranes, like, yes, you can use the collagen. I just love PTFE membranes. They're inexpensive. They're so easy to work with. I just absolutely love it. Implant placement, it's all about the digital plan, the right software, whether it's you, your lab, an outsourced facility, whatever it is. And then honestly, the 3D printed guide and the 3D printed healer, there are also some really good anatomic stock healing abutments that are also great that are on the market. But having an anatomic healing abutment is going to save you time down the road. And then finally, the true tooth replacement, which is your digital restoration. So the digital restoration is going to include the CAD camera, the abutment, the crown. It could be a 3D printed crown, and it's going to be your splint. These are all the things that truly change what it means to go to the dentist. Digital dentistry has changed my outlook on how I do things, how I approach life and everything, because it's given me purpose. It allows me to enjoy what I'm doing. It takes the right investment. You got to get over the cost. Like, yes, there is a cost to investing in these technologies, but I promise you the reward, the fulfillment that you get after this changes your outlook and everything. The way your patients speak to you, when they understand the care, the detail, the workflow, the everything that went into creating their restoration, they change their perspective of you as a clinician, which is why I love what I'm doing more than I've ever done before. I've gotten into teaching because of this. I even do a podcast, this Digital Smile Hub, because of this. It's what we do. So I hope you guys got away something from this, from the workflow standpoint. That's so important to me, is having the right tools, the right armamentarium, the right technology, because, oh my gosh, you can change people's lives in your own office. If you like listening to some, like, if I didn't bore you to death and you kind of like hanging out, like, my passion is digital dentistry. I love 3D printing more than anything. I love surgery, but man, I love smile design. I do a ton of smile design. I'm doing, Havid, I'm sorry, I'm doing a shameless plug for myself. I also teach with 3D dentists. I'm teaching a course in June. If you want to come hang out with me and discuss surgery, all this kind of stuff, I encourage you to come hang out with me. But you guys, it's been a blast tonight. I went a couple minutes over, but we started a little bit late. So I feel like I'm right on time. So let's hit some questions here.
Yeah, you are on time. Actually, very, very good on time. If you can, if you please stop sharing your screen so everyone can see
Nope.
your good smile that you
You know,
have.
Habib
Your
wanted me to, there we
analog
go.
smile. There you go.
God.
Terrific. So that's excellent presentation. Really well done. The digital aspect of it was tremendous. And there are a few questions that we have, and love to hear your thoughts on them. So first question came from Alice about what CE do you recommend to learn how to read CBCTs? Do you yourself have any courses, maybe through 3D Dentist or any other avenues?
So here's what I'll tell you, is that what's amazing about the digital world. So like 3D printing, the way I learned 3D printing honestly was like online. Like there's a boatload of resources on, and I hate to say YouTube, but there are a boatload of resources on YouTube. But a lot of times the cone beam manufacturer you purchase through often will have unbelievable resources, and they'll have KOLs that are tied to that company that have courses that they can either give you deals on or whatever. But I am a big advocate for in-person learning so you can ask questions. And so, especially with radiology and cone beam, like, just get out there and do it. Now, one of the things with radiology and cone beam that I think gets in the way of us as clinicians is we're very worried about the legality of interpreting a cone beam. What I will tell you after, almost dang near 2 decades of cone beam interps and all that stuff, is that it is so much easier to interpret a cone beam than an orthopentomogram or a Panorex. And the reason for that is a pan is superimposing everything, and you are responsible for everything that you're seeing. And so with a pan, there's so much overlay that it's so easy to miss stuff. But we're accustomed that it's appropriate socially and culturally and within our profession to interpret a pan like it's not a big deal. But a cone beam, it's like, oh my gosh, like we can't do that. What I will tell you is that it's so much easier to interpret a cone beam. I'm a big advocate of teaching your team this. So and you'll ask all my hygienists, like they're expected to interpret every cone beam they take. And we take a cone beam on every new patient. So they are expected to interpret and learn. And what I'll tell you is I can take fresh grads out of hygiene school and get them super proficient. And all it takes is one experience where they diagnose an oncology lesion or a big tumor or something like that. And it will change their passion for what they do more than anything. So don't worry about, like, just get into it, but ask whoever you purchase it through. The third-party distributors have a bunch of courses. 3D Dentist does a bunch with cone beam on all their implant courses. So just get out there, take the CE, but don't let that be a barrier.
That's excellent. If you don't mind sticking around, we have some more questions I'd like to
I'll be here
get
as
to
long
you
as you
with.
guys want. I'm here all night.
But I know you have a busy schedule. But before we do that, I just want to just let everyone know about the CE credits, because I know it's getting a little bit late, and also we have a special surprise. So we'll get to CE form in just a moment. But usually we have something very special at the end of every TBS event, especially our virtual clinic. And tonight, unlike no other, we have an extra special one, which is truly amazing. One of the things that you're talking about being efficient in your workflow and your design, and I think that the 3D dentist kit that we've actually created with all the different aspects of it, with the perforated periosteal, the curettes with the serrations that you spoke about
Yes.
earlier, ejectable scalpel blade, all these different little features to make you a little bit more efficient, not wasting bone, as you showed in the videos, but placing everything properly, which is very helpful. So I know Hasib has another special, as we like to call them here or special, as we like to call them in the Brooklyn terms. So tell us what you got for us tonight about the 3D dentist kit, and how are we going to go
Yeah,
broke at TVS this evening?
no. So I think Tim, the biggest thing that you are part of, and you give the story, is the workflow. I know when initially we came up with the 3D dentist kit, like our 3D kit, you were like, I don't know, man. I have everything that I use and stuff, and
Dude, all right, I got to interrupt you. You guys, I was the person, like, it was me by myself. I got this crazy Hasib guy in my office saying I need to get this 3D kit. And granted, I was teaching for 3D at the time, which is ironic. And I'm like, I already have these two amazing, what I thought were good enough surgical kits. I'm like, I don't need this. I couldn't have been more wrong. And Hasib loves to bring this up because I'm like, what I didn't realize was the workflow. Like, it was the way you use the instruments with intent. Like, that was the part that I didn't realize was so critical to my workflow. And now I have an associate and he doesn't want to use my old cassettes anymore. He only wants the 3D. So we have like this battle, and I'm like, Hasib, it'd be really nice if I could get some more cassettes. And the good thing I'm on tonight, because I think there's a way for me to do.
I think Christine Moore just agreed with you as well. She loves our surgical 3D kits as well. So tell us, what do
so
you have for us tonight?
in the honor of all this that you said, we did this special before. It was a very overwhelming response on that. But as a thank you to all people staying tonight, great presentation, Tim. I mean, I don't know how you squeezed everything in
Outstanding.
this an hour.
Outstanding.
Beautiful, beautiful presentation. We're gonna do another 1+1 on the 3D kit. By the way, the CE is over. We're gonna share that right
Yes.
now, but the 3D kit is $28.50. But if you order it on our website, we're gonna share this right now. The QR code. If you place the order on our website, you will be getting 1+1. So each 3D kit is going to be really really $1,600, which is a great deal. So if you are looking to increase your workflow, this is only special for our audience tonight. You have until tomorrow, 8 p.m. Eastern Standard Time. If you want to take advantage, talk to your doctors if you're an associate. But this will make your workflow and your just the way you approach surgery is the most efficient way to do it. So If you click on the
I
link
love
that
this. I love this deal because you actually get forceps in each. You get two rajors in each, and if you think about that alone, that's over
yep,
$1,000 worth of material right there, just in that. And then of course you get all the ejectable scalpel blades, all the mirrors, all the different
You got
features
an
of
Elvatome.
periosteal midsole. You have a free Elvatome, included Elvatome in there, which really everything you need, multiple
Yeah,
curettes. So
it's awesome.
everything that you need to have a surgery, including the Castro Viejo, which itself is retails at almost $300. So that's an excellent deal. I think that's very, very fair.
$1,400 for each
Yeah,
kit is pretty good.
not very happy about that deal, but we'll see how it goes tonight. I think slowly Hasib is trying to bankrupt the company with these virtual clinics. I think that's the overall message. But no,
No,
we do want
I
people to
will
get
I
out
will
there. I think
say
once you get a couple of these kits, you're gonna end up replacing all your inventory
yeah.
with these kits.
I will say this, that was the kit for me that, like in dentist, like we're always looking, like everybody's selling us something all the time, right? Like I'm almost like everybody's always trying to sell me something. I will say that the 3D dentist kit was the turning point in my journey with TBS and seeing them as a true company that listens to the dentists of innovating of like how we use things. And that's what's important for me. Like I want quality products that are very efficient and very tied into my workflow. And that kit just tied in, God, just tied in so well in my workflow, which is why like we've done so much other stuff with TBS because of that. So I think if you're looking to like, how would I want to try something? I think this kit is probably the best way to get into it, especially if you're doing any kind of surgery, whether it's implants, extractions, grafting, whatever it might be. It's kind of the one kit that allows you to do everything. So it's literally in my op for every surgery.
There you go. That's probably the best testimonial you could ask for right there.
Yeah.
The kit that does everything.
Solid.
Really well done. So we also want to mention that we do have a WhatsApp group. Christian, if you wouldn't mind posting that. We do have a WhatsApp group that you can please feel free to join with us there. We have post questions. We'll post the latest virtual clinics. We have some upcoming virtual clinics in the near future. You can see it all there. So please, you can visit that also at tbs.com/education. You can see all of our future meetings. We have the next one coming up on April 2nd, I believe, which is managing and resolving ridge preservation and complication and predictable outcomes. It's going to be a great lecture as well. So please join us there. You can see that QR code there for our WhatsApp group. So please join on there, ask questions there. You can feel free to join us on that group and see a lot of access to our other speakers and that have been previously on the virtual clinics as well. So I do want to get back to some of these questions because there were
Yeah.
some really excellent questions.
I was reading through them. There are some good ones.
Yeah, they're pretty good ones. So you were talking about gluing together the custom healing caps onto the tie bases, and that's a big plus right now. Going direct to the implant, depending on the implant, sometimes
Yep.
you can squeeze with it too much. Sometimes that composite can break or fracture. But just curious, what is your preferred method? Are you going direct? Or are you luting? And if you're
You know,
if you are
it's a
luting, what are you
mix.
luting
Like,
with?
so here's, I'm more and more apt, mainly because I think I'm lazy. I like the tie base because it's so predictable and it's so quick and easy. And to be honest, you can actually reuse the tie bases. I know it's controversial, but I use on the same patient, not on other people. But the way I lute them to the tie base is I just micro etch with aluminum oxide, the tie base, and then I will use either, honestly, like the multi-link by Ivoclar to just cement that on there. Here's the deal. You can really do anything because these are not under any torque, pressure, anything. They're literally just sitting there. So you probably could even just use the resin from the cement and it probably, or from the print, and it'd probably stay. And that's one of the things that everybody gets hung up on. Like, oh, I need stability. It's going to come off. I'm like, no. It won't come off because there's nothing putting pressure on it. It's just sitting there.
Yeah, it's not in function.
Yeah. Just why am I drawing a blank? What's Ivoclar's abutment to tie base cement? The multi-link. Yeah. So that's usually what my team members are putting on.
And
Good
that's great.
question.
And you can do that. It's very easy to just bond on.
Yeah.
The next question was same thing, but related to that. So placing the inserts prior to curing the guide.
100%, you guys. That's a big tip there. Place the insert prior to curing. If you cure it, it is exponentially more difficult to get a tight fit. And so there's a lot of different parameters based on your software. You can kind of tweak that so it's pretty consistent. With exocad, I've got a really dialed in parameter. So if you want to message me, I can give that to you for the exocad users. But if you put a little alcohol, one, it's pre-cured. So you just pop it out of the, you've washed it. So it comes out of the printer, it goes into the wash box, it comes out of the wash. Then you put the sleeve in, then you cure it. That's really, really important to making your life simple. Good question though.
I'm saying, what about going without any sleeves at all?
So that's
Any inserts at
dependent
all?
on your implant system. I place a lot of BioHorizon implants, and so for me, their sleeves integrate with their guided kit. So if your guided kit system is a sleeveless and it's a true guide tube-less. Is that a word? I don't even know if that's a word.
Yeah, I guess you just made it up.
I just
Sounds
made
good
it
to
up.
me.
Then you can. The risk with that, the reason I don't love that is that, I mean, your osteotomy drills are very sharp. So if in those cases that are tight, it's really easy to bind against. I mean, I've literally bound a drill into the guide tube. And so it's really easy if you don't have a guide tube to cause it actually to cut into the guide and then transport that everywhere else. So I don't like that unless it's built in your system. Most systems have some form of guide tube, but just follow your implant system for whatever guided surgery that they're doing.
And Christy's wondering if she can get, I think, the STLs for your healers. Are those custom or are those your own?
Even better, you guys, they're totally free. So the custom healers that I use, so there's two different ways to do this. One way is using a free software called the Anatomic Profile Generator 2. Just Google it. It'll pop you. If not, like Baron Grutter's website has it.
I was going to say Baron.
Yeah, it's a free software, and all you do is you pick your platform of your implant, and it literally generates it for you. Now, the other system that works really, really well is that you can use true abutment to actually design. What's unique about true abutment is they allow you to design an abutment. You just design it to the gingival level. So what I do is I've taken the three different platform, or now two different platform sizes of implants that I use, and I've designed an implant abutment for that, and then I just reprint that multiple times. So that allows you to go to direct to fixture. The other thing is more and more implant companies are coming out with anatomic stock abutments, and that's okay too. Like, I'm not trying to copy the anatomic abutment into the crown for this purpose. I'm just trying to set myself up for success when I get to the impression process, so that I don't have this tiny, tiny strict collar that I'm having to do an incision or laser or do some crazy stuff like that. So if it's anatomic, great. If not, just use the anatomic profile generator. Like I said, I just print a boatload of them. If you're a BioHorizon user and you need some of those, like specifically like the 3.5, just message me on Instagram. That's probably the easiest. Tim Anderson DDS on Instagram. I will send you the link. I've created all of them, so that way you don't have to deal with the software. So just message me and I will get all of that to you.
I'm just posting the link as we speak for Baron's website, where you can see the generator. It's excellent, excellent website, software. And Baron's an excellent designer. By the way, if anyone's looking for a designer, Baron is terrific at doing full arches and more.
He's one of the godfathers of printing.
The originals. Yep. And hopefully we'll see him in IDS next week in Germany. He's typically a visitor out there. So I did have my own question. You were talking a lot about PTFE, which
yes.
I'm also a big fan of myself. Have you tried using, you mentioned pericardium, have you tried using the TBS pericardium as an open membrane fashion in the same manner?
I haven't tried so I've got some, and I haven't tried it yet. That's the
next thing we have to,
so that find you a patient. Yes. So I actually, so let me take this back. I have used it on a patient. I just don't have the follow-up yet. So
Okay, that's
I'm
fair enough.
it's in documentation. But yes, I'm very what I'm excited about, like what I'm excited about this is that when you have, I love working with companies that share visions that I have. Like we have the same cultural vision, philosophies, values, morals. And one of the things I really value about the philosophy on TBS is it's not just a one-trick pony. It gives you a solution. And I'm a solution-driven individual where I need a way to get from point A to point B. I don't want just the midway stop. Like I need to get the whole way. And so having the ability to have a kit and a strategy to remove the tooth and now graft the tooth, that sets me up for my implant workflow. And so the extract and remove and fill with TBS, like I love that concept of a streamlined workflow. I love workflows. It's good for my team
That's
too to have
actually
consistency.
that we've been hanging around Hasib a lot because he's
I know.
exactly all about that, about solutions in dentistry. And I think that's where he's
Oh,
going to
look
be.
at
Look
he
how he's
popped back on.
smiling.
He
Look
popped
how he's
back on.
smiling. The best hair in dentistry. Both of us bald guys and
I
this guy
know.
with the amazing hair. Best hair in dentistry. Get us
Oh,
a solution for hair. Do us a
yeah.
favor. You
That's
And
a
know?
big,
I don't want to
big
travel to another
marketing
country
job.
either. So
Yeah.
That was really well done. And your slides are terrific. They're main podium worthy. They're really terrific about the workflow that you had, the way you pinpointed everything so accurately, and you provided tonight for every dentist that's attending a solution. And I think that as a lecturer myself, that's really all we can ask for to do is to try to give people a solution. And you provided your solution tonight. It was really excellently documented. Great job. All presentations should be like this. It was really, really well done and thorough. Besides the cool animations and the motion background that is new to Keynote for anyone who hasn't seen the latest, you download the latest Keynotes. We've been using those for just only a little time now, and they are a lot of fun. For us as presenters, it's fun
oh,
to be engaging. Even the TBS colors in the background, all the attention to detail that you did, didn't go over our heads. It really it hit us there, and it was superly well put together. If
I
that's a
appreciate
word,
it,
I
man.
think I just
You
made
guys
that up too.
part of my family. I like it. So no, it's anytime. It's been fun. But I do want to anybody who's still on here, like I do want to emphasize, like I'm an open book. I want, if there's anything you guys need, reach out. Like dentistry is a small world. It is a crazy small world. We're here to help each other. I've learned everything I know through
Amen to
other
that.
people. So I've not invented anything myself. I've literally ripped it off and done it from somebody else. And so we're all better for the people that have come before us. So you gotta take an initiative, reach out to people, take that leap of faith, and you will not regret it.
Very well said. Very well said. And Christian just posted again the WhatsApp group. That's how you can find us. You can ask questions and meet us on WhatsApp and continue to help. We'll all try to help you find solutions if you're interested in another instrument or something like that that we can try to help you work with, or just a technique of some sort. That's what it's there for, and it's growing very rapidly. That WhatsApp group. So it's really taken off. So we're honored
And
again. Yeah,
Hasib
go ahead,
posted
Asim.
my email, and I promise you guys I will not respond to that. So don't email me. DM me on Instagram. Trust me, I will not respond to an email.
Or
So
if you guys want to get a hold of Dr. Anderson, contact TBS.
there you go.
Get a hold of him.
That's awesome.
But Dr. Anderson, again, thanks a lot. This was a very beautiful put together presentation. I know the amount of effort and energy that you put into this. We really appreciate it. And for all of our attendees, stay tuned. There is a lot more coming. Dr. Anderson just gave us a very little teaser of what he is really known for and what he does. But in the next future, these will be different segments that we want to do. We really want to drive dentistry forward. We want to push the envelope. We want you to do more procedures, be more efficient with those procedures going forward, and just focus on that. And that WhatsApp group, that is our clinician group as well. We don't post any videos, any marketing material. It's strictly education. Thank you all for joining us tonight. If you are looking to invest in something that's a great product, please follow that with a BOGO on 1+1, and watch TBS education in our emails going forward for more information. So thank you all.
Yeah, we have
Have a
we
good
have
night.
April 2nd. We have April 2nd, Dr. Ashwas Surya, managing resolving ridge preservation complications. Then coming up after that, April 16th, we got Dr. Ford back with us again, Dr. Gans with us, April 29th. We have a tremendous amount of speakers, and tonight's speaker again, Dr. Anderson, was terrific. So really thank you so much for your attention this evening. Dr. Anderson, thank you so much for joining us. I look forward to having you back again with us and hope to see you soon in person and talk a little bit about more 3D printing and whatnot. It's really near and dear to my heart. So again, really amazing job, and really thank you everybody for joining us tonight.
Appreciate it, guys.